Human papillomavirus, commonly referred to as HPV, is one of the most widespread sexually transmitted infections and the leading cause of cervical cancer, anal cancer, oropharyngeal cancer, and several other cancers related to the reproductive organs of both men and women. For decades, HPV vaccination campaigns have mainly focused on adolescents and young adults, primarily because the highest preventive effect is achieved before sexual debut. However, as the global population ages and sexual behavior patterns change, an increasingly common question has arisen. Is HPV vaccination necessary for middle-aged adults, namely those between the ages of 35 and 55? This is not just a medical issue, but one that touches on economics, social attitudes, and perceptions of disease prevention. To answer this, we must look at multiple angles, from how the vaccine works, the risk of HPV infection among middle-aged individuals, the potential benefits of late vaccination, financial considerations, the official recommendations of major health organizations, to individual factors such as relationship history, baseline health status, and long-term preventive goals. First, it is crucial to understand that HPV is not a single virus, but a large family with more than 200 strains, of which about 14 are categorized as high-risk types due to their ability to cause cancer, most notably HPV 16 and HPV 18. The primary mode of transmission is through skin-to-skin and mucosal contact, particularly through unprotected sexual activity. In most cases, HPV infections clear on their own thanks to the immune system. Yet in roughly 10% of infected individuals, the virus persists and induces cellular abnormalities, eventually leading to precancerous lesions and cancer. The HPV vaccine was developed to prevent this by stimulating the body to build immunity before encountering the virus. That is why the maximum protection is achieved when vaccination occurs before sexual debut, usually between ages 9 and 14. So why is there still a rationale for middle-aged adults to consider vaccination? A common assumption has long been that once an individual reaches adulthood, enters a stable relationship, or has a steady sexual life, the risk of new HPV infection becomes negligible. Epidemiological data, however, show this assumption is not entirely accurate. First, HPV can be contracted at any point in life, not just in youth. Middle-aged adults remain at risk, especially when entering new relationships after divorce, widowhood, or partner changes. Second, research indicates that HPV prevalence can rise again in midlife women due to immune system decline with age, which may reactivate latent infections that had been dormant for years. This suggests that the risk of cervical cancer and other HPV-related diseases does not simply vanish after age 30, but persist well into middle age. It is also important to note that while the HPV vaccine does not cure existing infections, it still provides protection against strains that the person has not yet encountered. With more than 14 high-risk strains and newer vaccines now covering up to 9 of them, such as Gardasil 9, no middle-aged adult is completely immune. For example, someone may have been exposed to HPV 16 but not HPV 18, and vaccination could still provide meaningful protection against the latter. From a guideline perspective, the U.S. Centers for Disease Control and Prevention, CDC, currently recommends routine HPV vaccination for children aged 11 to 12, though it can start as early as 9, and catch-up vaccination up to age 26. For adults between 27 and 45, the CDC does not recommend universal vaccination, but instead advises shared clinical decision-making. This means that under certain circumstances, vaccination may still be appropriate for middle-aged adults if they are at risk of new HPV exposure and desire additional protection. The World Health Organization, WHO, and other leading health agencies worldwide echo similar guidance. The optimal benefit comes before 26, but that does not mean the vaccine is worthless after that age. It must be emphasized that vaccine effectiveness declines with age, not because the vaccine itself is weaker, but because older adults are more likely to have already been exposed to multiple HPV strains. Therefore, the incremental added immunity is not as substantial as in adolescents. Nevertheless, studies in the U.S. have shown that HPV vaccination still significantly reduces the risk of new infections and precancerous lesions in women aged 27 to 45. While the degree of benefit may be smaller than in younger cohorts, it is still measurable. From the perspective of middle-aged men, HPV vaccination is often overlooked. Yet HPV is also responsible for penile, anal, and oropharyngeal cancers, as well as genital warts. Vaccination can dramatically reduce these risks, especially at a time when HPV-related throat cancers are rapidly rising among middle-aged and older men in developed countries. Thus, HPV vaccination for middle-aged men deserves serious consideration. Individual circumstances play a large role in decision-making. Factors such as marital status, number of lifetime partners, prior medical history, immune system health, and even occupation. For example, healthcare workers may face higher risk. All matter. Middle-aged individuals with weakened immune systems, such as those living with HIV, organ transplant recipients, or patients on long-term immunosuppressive medications, are more vulnerable to severe HPV complications, and vaccination could provide significant protective benefits. On the other hand, cost is a non-trivial factor. HPV vaccines are relatively expensive, particularly the 9-valent version. With a 3-dose schedule, total expenses can easily amount to several hundred US, sometimes more depending on the country and healthcare system. In many regions, insurance coverage stops at age 26, leaving middle-aged adults to pay entirely out of pocket. Thus, weighing the balance between benefit and financial cost becomes a practical issue. There is also concern that receiving the HPV vaccine in midlife may give some a false sense of complete protection, potentially leading to neglect of regular screening. In reality, even after vaccination, women must continue routine Pap smears and HPV testing to detect early cellular changes. Vaccination is not a substitute for screening, but rather a complementary measure to reduce the risk of new infections. A further social factor lies in cultural acceptance. In many societies, HPV vaccination is still closely associated with sexuality, sometimes generating stigma or misunderstanding. Middle-aged individuals may feel awkward seeking a vaccine intended for the young, or may believe it is too late to benefit. Public health messaging must emphasize that HPV is fundamentally a cancer-related virus and not simply a matter of sexual morality. From an immunological perspective, another important question is whether the immune response in middle-aged adults is as robust as in younger individuals. Research shows that antibody production still occurs and remains stable for years, though titers may be somewhat lower than in adolescents. Nevertheless, the immune response remains sufficient to confer substantial protection. Several clinical trials in women aged 27 to 45 have demonstrated that vaccine protection lasts at least a decade, comparable to younger groups, although longer-term data are still being collected. This suggests that vaccination in midlife could still be considered a worthwhile health investment with durable benefits. The difference in benefit becomes clearer when comparing individuals in long-term monogamous relationships with those at higher risk, such as people recently divorced, widowed, dating new partners, or engaging in unprotected sexual activity. For the low-risk group, the incremental benefit may be too small to justify the cost. For the high-risk group, however, vaccination can be a valuable protective strategy. Another relevant dimension is vaccine innovation. Newer generation HPV vaccines continue to expand coverage to more strains, which means that even previously vaccinated individuals might consider additional doses. For example, a person who received the 4-valent vaccine, covering HPV 6, 11, 16, 18 years ago, could potentially benefit from the broader 9-valent vaccine. In conclusion, HPV vaccination for middle-aged adults is far from meaningless. While the optimal window of protection is earlier in life, there remain tangible benefits for individuals aged 35 to 55, particularly those at higher risk, or those who wish to minimize their long-term cancer risk. The final decision should be based on personalized consultation with healthcare providers, weighing benefits, costs, health status, and one's tolerance for risk. What is most important is that whether vaccinated or not, middle-aged adults must continue routine screenings, practice safe sex, and monitor their health over time. The vaccine is a powerful tool, but it works best when integrated into a broader commitment to proactive healthcare.